Hi, I'm Dr. Betty Maloney, and I'm here on behalf of I.L.A.D.s, the International Lyme and Associated Diseases Society, to talk about Lyme disease. And the program is called What Every Primary Care Doctor Should Know About Lyme Disease.
What do primary care doctors need to know?
Well, I'd like them to know everything, but in the interest of time, let me break it down into 4 main points. The first one is Lyme is a tricky diagnosis to make. The treatment of Lyme patients needs to be individualized because they're very different and they present in many different ways. We need to recognize that treatment fails. And finally, that all of the controversy swirling around Lyme disease really is rooted in scientific uncertainty. There's just a lot that we don't know. For instance, we don't even have good biomarkers of the infection. So we don't have reliable diagnostic tests, and we don't have any tests of cure. And so until we get good tests that tell us who's infected and who isn't, and who is persistently infected and who remains ill due to other causes, we're going to continue to argue about how to diagnose and treat Lyme disease.
Okay, let's talk about chronic Lyme disease.
Well, sure. Chronic Lyme disease is a term that I try to avoid, and I do so because it's not really clearly defined and people use it in different ways. It's got a lot of political baggage. So I think a better term is persistent Lyme disease or persistent Lyme borreliosis. And when I use that term, what I'm talking about are patients who have been diagnosed and treated for Lyme, but who remain ill with symptoms that are compatible with Lyme disease. And in this group of patients, we've looked for other potential diseases that would explain all of their symptoms, and we can't identify an alternative diagnosis. And we want to make sure that these people have no history of being reinfected, because that might be the cause of their symptoms. And then finally, what we want to do is recognize that there is no specific lab test that can identify persistent Lyme disease. So really we have to be careful and make sure that we've ruled out other potential diseases.
So are these people with persistent disease, are they actually still infected?
Well, not necessarily, although some certainly are. And so when we think about what might make someone ill and keep them ill, there's many possible mechanisms. So perhaps someone is infected with another tick-borne disease. We know that the black-legged ticks transmit many different pathogens, so it could be that you've treated the Lyme satisfactorily, but there's an undiagnosed, untreated co-infection. Another possibility is that they have tissue injury from the Lyme disease that may be permanent or just slow to resolve. People might have a secondary condition that was either unrelated to Lyme disease or it was triggered by Lyme disease and now it's causing the symptoms and not an infection. There's been the hypothesis that there's immune dysregulation, so that the infection triggers the immune system to behave abnormally, and that now it's spinning out of control, and that is the source of symptoms. But despite all of these different possibilities, the one that actually has the most evidence is persistent infection. And the evidence that we have for that, it comes in all different forms. And so in animal models, mice, dogs, ponies, non-human primates, persistent infection is routinely seen. And then we have examples, case studies where people have been persistently infected following one or more rounds of antibiotic therapy. We have some evidence from erythema migrans trials. So in a couple of European trials, they would take a punch biopsy from the rash prior to treatment. And then after treatment, they'd wait a few months and they'd re-punch that same area. And in some of those patients, they were still culture positive. Patients would get retreated and then they'd re-punch, and then the infection would be eradicated. So from EM trials, we see not only evidence of persistent infection, but also the value of antibiotic retreatment. There have been studies of late neurologic Lyme disease where patients were treated, relapsed, retreated, and then remained well. And incidentally, in many of the erythema migrans trials, when patients remained ill or the researchers thought that they were treatment failures, they would retreat those patients and often report that subsequently the patients were well. And so that's some of the evidence for persistent infection. And there was recently an NIH study, a xenodiagnostic study, where they actually took uninfected ticks and put them on people to see if they could recover the evidence of the bacteria. And so, interestingly enough, they had several different patient types. They had one patient who had a fresh rash, and they used that patient because if it ever was going to be a positive, it should be in that person. But they also had patients who had been treated for Lyme disease and remained ill. And of those 8 patients where they had recovered enough ticks, what they found in one of those patients, they were able to pick up DNA from the bacteria, and this person had been treated 400 days earlier. So having that bacterial DNA around is very good evidence of a persistent infection.
Does antibiotic treatment help?
Oh, good question. So even if people concede that persistent infection is a possibility, often they'll say, but retreatment doesn't help. And as I mentioned, we know from the EM trials that that's not true, that retreatment can help. And in Logigian's trial of the patients with Lyme encephalopathy, he had a patient that relapsed and retreatment helped that person. And then we have the 4 NIH-sponsored retreatment trials, 2 by Dr. Klempner, 1 by Dr. Krupp, and 1 by Dr. Fallon. And the Krupp and Fallon trials are interesting in that when they looked at their patients and treated them, that people with severe disabling fatigue clearly benefited from antibiotic retreatment, and the benefit was sustained. Now, other groups might not do as well, and so one of the tricks with retreatment is trying to decide who needs to be retreated and what would be the most likely antibiotic regimen that would help them. Because not only do we have to consider what regimens might be useful, we have to take into account cost and safety. And so we really need more trials to tell us which is the best approach. But clearly, antibiotic retreatment is appropriate for some patients with Lyme disease that doesn't go away following their initial therapy. Let's talk about, when we talk about Lyme disease, it's really critical for people to recognize that there isn't a one-size-fits-all approach. Patients are very heterogeneous, and what that means is that no 2 patients look alike. And that has to do with how this bacteria works in the body. Once it disseminates from that site of the bite and gets out of the skin, it can travel anywhere. And depending where it lands, you're going to have different problems. So some people will have problems because the bacteria has infected a joint. Other people will have problems because it's made its way to the brain or to the peripheral nervous system. And so how we approach the infection depends not only on where it is, because it's sometimes harder to get antibiotics into some body tissues than others. It also matters, well, how was this patient before they got ill? Did they have other conditions that might impact treatment? Do they have problems with their immune system? Do they have other medications that might interfere with antibiotic treatment? Do they have other conditions that might heighten or lessen their symptoms? So you can't take a one-size-fits-all approach and expect to get good results. Thanks for watching. I'm Dr. Betty Maloney, and if you'd like to learn more about Lyme disease, make sure you check out ILADs.org.